seconds, man. Get out of here.
Welcome to another edition of Spinal Oncology Debates. I, along with my co-chairs, Dr. Mohammed Mackey and Dr. Joe Schwab, and my name is Dan Shuba, are so thankful for you coming today. We have a great half hour picked out here, but first things first, we want to thank the Seattle Science Foundation for this wonderful platform, which we all benefit from learning on this. We'd also like to thank NASS, the North American Spine Society, from which we're all members of its spinal oncology group and help support us through their society. And then finally, I'd like to thank Icotech through their generous industry support that helps defray some of the costs to bring such an educational opportunity to all of us. So without further ado, I'll start off by introducing Dr. Joe Schwab, who's one of the co-chairs of this format, and he's going to introduce the speakers for this edition today. Thank you. Take it away, Joe.
Thanks, Dan. We're real happy to have two great members of the spine oncology section for NASS. We have Hawa Wu from UC Irvine and Dan Tobert from Mass General Hospital. And they're going to speak today or lead a discussion today on something very practical that we all face, and that is whether or not to reconstruct the anterior column, particularly in patients with metastases, something that we often have to decide and is debated frequently. So thanks so much, Dan and Hawa. Take it away.
Thanks, Dan. Thanks, Joe, and thanks for this opportunity. I think I agree this is a very practical question, one that I think about a lot. And I think, when trainees hear about a costotransversectomy going down, they always want to know, are we reconstructing? Are we going to put in one of those cool expandable cages? This is something that, to me, I looked to the literature to try and solve when I was first starting out. And fortunately, there's a lot of data, but unfortunately, it's a lot of retrospective data that can be difficult to point in the right direction. So perhaps maybe I'll throw it to Hawa here and say, Hawa, you're now 3 years into practice. Let's start with maybe a thoracic spine mets. Are you reconstructing it if you're going ventral to decompress the spinal cord?
Well, first of all, thanks, Dr. Tobert. And I just want to give a shout out to Dr. Tobert and Dr. Schwab, who are my mentors in fellowship. So a lot of what I do now, I learned from you guys. But it really depends. And I think the interesting part about this discussion is that, when we're talking about metastatic spine tumor, typically we're talking about palliative treatment for our patients, but our patients are living longer and longer because of the treatments that are afforded to them from immunotherapy and medical therapy. So I think for me, I think that there's a prognosis of a year or more. That makes me more likely to do anterior reconstruction. But for the majority of patients, and also the fact that prognosticating is difficult, I'll just do usually separation surgery with a transpedicular decompression, an instrument just posteriorly above and below.
Yeah, I think to me, I started out by doing a decent number of reconstructions anteriorly, but I think if you ask me to single sentence describe, I'd say I would have to really find a reason to reconstruct in the thoracic spine. And to me, there's really kind of two variables that are most important. One, which you hit on, is the prognostic piece. It's a much different story if somebody's, being diagnosed with treatment-naive prostate cancer and they have a really long runway, multiple years, versus something like a lung adenocarcinoma with a PD-L1 expression of less than 5%. We know that their life expectancy is unfortunately going to be really quite low. The data, for example, you can look at papers, and I read one paper that reviewed about 60 cases that said that there really was no difference in operative variables and clinical outcomes when reconstructing. And so the argument there was that if you need to, it's a possibility and a treatment decision, for us surgically that potentially doesn't have much morbidity. But I think for me, Dan Tobert starting out day one, trying to reconstruct a cage versus perhaps now, to me, it would be much, longer and more difficult to do that starting out than to a more experienced surgeon. So I think there's all these little details that matter. And the second detail aside prognostication is the location of the spine. I think the thoracic spine really has biomechanically a lot of tolerance because of the rib cage, as opposed to the lumbar spine. What do you think about location?
Yeah, I think that's a great a point there, just because when we're talking about the lumbar spine, then you can even go into deformity principles. Like if you're down at L5, you have a pathologic fracture, and you're worried again that the patient, has a longer life expectancy than just 3 or 6 months. They're going to live for, quite some time. Is it worth reconstructing that segment to get some lordosis? I think there can be an argument made there. And then when the lumbar spine, there's more options in terms of approaches. You can think about doing laterals, prone laterals, anterior work as well. So I think that is a consideration. But I think at least fortunately so far, and what I'm seeing at UCI, it's been predominantly thoracic spine, but I have had a couple of cases in the lumbar spine where we've had those discussions.
And in terms of, let's say there's a scenario where you are reconstructing, are you using expandable or are you using static cages?
Yeah, and I think that's where, in terms of the cage or not to cage discussion, is interesting, because I think now for me, I like the expandable cage just because it's a lower profile implant when it goes in, so you're less worried about injury to the nerve root. I mean, I guess usually in the thoracic spine, you're able to take down that thoracic nerve root and there's adequate space, but it does allow you to get a pretty good fit there, and not have to mold something or try to fit something in if it's static.
Yeah, I think the the definitely can do less morbidity with a expandable cage. I think the topic you brought up on immunotherapy is also pretty important as well, because the disease progression really starts to get me worried about the complication profile of reconstruction. And so, I think we can make an initial X-ray look really good, put in an expandable cage. But if disease progresses and we start to get adjacent vertebrae involved, fractures, and then all of a sudden we have a loose cage in somebody who's pretty, frail, and trying to undergo treatment, and then we're trying to make decisions about whether to stop treatment to go and fish that thing out. That's when I start to really spin a little bit into circles, as I'm, trying to decide things preoperatively.
Yeah, absolutely. I'm actually curious about the folks we have in our panel, what their preference is for cage.
Joe, why don't you go ahead?
Yeah, to be honest with you, specifically for patients with metastases, so I frequently don't reconstruct the anterior column. If in the patient I think is going to live quite a while, or I've removed more bone for same sort of a reason, then I often will use methacrylate. So I'll end up taking an acetabular screw and inserting it into the vertebrae above or below, with the articulating screwdriver from the total hip set. Anyway, and then I backfill that with cement. I find that to be pretty forgiving. And I don't really like using expandable cages I mean, I think they're very good. I just personally don't like to use them in most of my settings. I'll either use a static cage. In this setting, I use cement.
Yeah, maybe I'm of the same peer group as Joe, where I remember we were some of the first to use expandable cages and publish on it. And then I've leaned away from that in some cases, because if you can fit something big enough, you can either use a static cage where it really loads it. And if it's too small, then maybe you're not putting a cage at all. And then in something that it's amorphous, the edges are not normal, or the bone is very weak. Cement, for the people listening who haven't used cement, what we're talking about is just to add on to Dr. Schwab's point, he's putting a screw above and below, because cement, even though it's called cement, doesn't really stick to the bone. It really just acts as a loading blob or a loading block. So in theory, it could actually, shift a little, or not necessarily fit perfectly. So when it goes around something else, like a pin or a screw or a chest tube, sometimes we'll use chest tubes as scaffolding, it can form this, and it can be really nice, and it can be cheap, and it can insinuate in a good way in all the areas that maybe you wouldn't make a perfect cube. I think for the Mets, these are the options. I think for the primaries, we are doing full reconstructions where we're taking everything out, usually with negative margins, so a very big piece, and then we're putting sometimes even vascular graft in there. So again, for the listeners, I think it's metastatics are getting less and less invasive as we can make them. Try to get them in and out. If you think you can handle the without an anterior column support, depending on if it's a stable part of the spine with the rib cage, et cetera. And then on the primaries, I think we're being more aggressive because we know if we cure them, they become degen patients and they'll fracture rods and they'll pull out. So I think for the metastatic patients, overwhelmingly. Mo, I'd love your thoughts about what are the factors that make you say cage, and what are the factors that make you say no cage?
So I'm gonna challenge my more senior and far more experienced colleagues here a little bit. Well, first of all, I don't really use cages much in metastatic cancers, with the exception, but all my patients will get a standing scoliosis film, and I will make sure that they don't have a focal kyphotic deformity, which is usually true in patients who have met at the thoracolumbar junction or at the cervical thoracic junction. And if in fact they do have kyphotic deformity there, I will use an expandable cage. I just find it easier to put in a smaller cage and then really expand. I don't think it damages the end plates much if you really take the time to do. I mean, a lot of the times for those cases, I'll even do bilateral transpedicular approaches, really do meticulous disc prep or end plate prep to ensure that I'm not damaging my end plates for that expandable cage.
Yeah, I think it illustrates the point. It comes down to your comfort level, and there are things that some surgeons do that they make it look very easy, and it is easy to them, and that's what they should do. And I think we all kind of find where our comfort zone is. For me, methylmethacrylate works really well in those settings. And I generally don't like if I haven't used anything to actually correct kyphosis. I usually we'll try to either let the table correct the kyphosis if they're that unstable. If they're fixed and it's not too bad, I obviously will frequently just leave it. I don't get too aggressive with fixing focal kyphosis. I'm not sure if that's the right thing or not, but I tend to be less aggressive.
Yeah, and I would just follow up both of your comments, Mo, especially with the most common. I don't know the market data, but I would say overwhelmingly when cages are used in this setting, in the current market in America, I bet they're mostly expandable. So that's what we've all used, and like I said, sometimes I go back to my roots and try. It's back to the future, if you will. But for the people listening, this is a very common thing. And all I'd say is these devices have become very sophisticated, where you can make them very small, make them very large, but they're also sometimes very powerful. So being understanding of those end plates, which I think Joe mentioned, and not totally trying to lift the patient off the ground with the full force that you can do with some of those ratchet devices. So you just avoid plunging and subsiding into the levels above. Just to remember, they are such a good. Some of these are so well engineered, which is great, and just sometimes realizing that they can generate a lot of force. Be careful on those end plates.
Yeah, another point I wanted to just follow up on yours, which I think was great, is that the cement really can act as like a customizable cage where it can really intercalate into all those different little crevices that you make during a decompression surgery. And that's where I think that the location really matters because of the kyphosis, for example, having the dorsal aspect of the vertebral body larger than the ventral. If you fill that whole space, then you have a wedge that can really back out unless you're putting in a screw like Joe was describing to keep it from doing that. Less so, I think, in the lumbar spine where you have a smaller aperture, so to speak, in the dorsal aspect of the vertebral body. But I think that's a real concern, at least for me, making sure that the cement block or whatever it is goes in is rigid, either through a screw like Joe was saying, or through it intercalating into some sort of portion of the body.
And also, I was curious about your guys' take. Does cost ever play a factor in this too? Are you guys getting any pushback? Because I do. One of the things that we at UCI, sometimes we get a report at the end of our case about how much our case costs versus the average, and that's been more and more of a factor.
Yeah, I haven't been receiving those so much here, but I used where I previously worked, I did receive those sort of public shaming, sort of a way of altering your and actually though it does make you it actually worked. I thought about some of the things I was doing, and when you start seeing the costs, it does sometimes help, and many times I had no idea how much things were costing, and so once you know that, if you think something's equivalent, that might push you one way or the other.
Yeah, I would echo that. One, I did have this at my former place, and then we're now doing it at my new place for the very reason that we're not expected yet to pay for our implants or the patient to literally pay for their implants. But when you see the price, it does allow you to, whether it's conscious or subconscious, create a value, analysis there, whether what you're getting in terms of benefit over cost. It starts being relative. So you sit there and go, wait, that one device costs more than all the other devices combined. It does at least make you think. I think what it does, which may be even more important, is I've seen people in the past where they were almost, it's like when you go to a buffet and someone like puts like so many shrimp on their plate. They like put all the shrimp on all the crab legs, whatever they think is the most valuable, and they eat like two. And they say, well, I paid one price. So, and I think that that's not true. This is an a la carte thing. So when you see that, I think people sit there and say, let me put that cage in. Well, I don't like this cage. Let me put the other one. And the reps are sitting there going, you just spent that cage. Now they don't sit there and say, maybe I just get all those shrimp because it is a penalty each additional shrimp. And maybe they're thoughtful about exactly what do they need for this case. Whether they're paying for it or not is helpful. And then I think when they start talking about other alternatives, if they feel that that's equal in terms of efficacy or efficiency or what have you, and one is twice as much, I think surgeons do change because they're shoppers too. So I don't think it's meant, and I don't want it to be, at least at our center, where you're shamed, as Joe said, but there is some element of that. But just seeing the price, even though a lot of us have the ability to use some of our disposable income at restaurants or supermarkets, we still look at prices. And a banana, I can afford $10, but a $10 banana, I feel like I'm being ripped off. So I do think seeing the prices is actually a little transparency that may help us, and we start talking apples to apples. So that was a soapbox, but about cost containment. But I think it is still net positive to see the pricing as opposed to the net negative of shame. Yeah. What about you at your place?
Yeah, I
We
was
don't
going to
have
say
any.
that.
Yeah.
No,
Go
go
ahead.
ahead.
I was just going to say we don't have any much financial constraints, but again, it's rare that I will use an expandable cage for a metastatic case. Please go ahead, though. Sorry to interrupt.
No, sorry. I was gonna make a brief point because I thought that was a great analogy. I mean, yeah, maybe you can afford the banana, but if you're getting charged $10 for it, it does feel pretty icky to pay for it. And I think there might be other folks that are watching our presentation right now who might be in resource limited settings. One of the things that we're doing at UCI right now, we do have some academic partnerships with surgeons who are in Nepal, Ethiopia, and Tanzania, where cost really is a big consideration. So when we're thinking about anterior reconstruction, a method where using the acetabular screw with cement, that might be the only option available. There might not be a cage that can be placed in that situation. So I think it's really important to understand those techniques.
Yeah, just to go on that before our next question from Dan Tober, but I remember when the last time I visited China, which has, is obviously got plenty of money in terms of the world economy, but their setup, at least when I was there last, was that the patients really had to help pay for the implants. And if they didn't have enough money, there was almost this rationing. And I would see, en bloc spondylectomies routinely done with 2 screws above and 2 screws, just a 4-screw construct. And I'd say, this seems like you might want to put more screws. And they said, this is how much money they have. And as a result, they're gonna lay in bed for a few weeks until they heal. But the hospitals there are not as expensive. So they have it exactly opposite. The hospitals don't charge much, but the implants are expensive. And here, we seem to spend more on the implants, and maybe the hospitals are telling us to get the patient out quickly. So a different dynamic where we might use more implants here in hopes that they leave the hospital there. less implants because that's the patient paying, and then the hospital stay wasn't expensive. So we are somewhat prisoners of our setup, and we should be flexible. I don't think that we should totally put that on the patient, but we all have to be thoughtful about, given our resources, what we can do. And I think the cement is, again, a back to the future, because some of these devices are so cool, but they are very expensive. And now I would love to, Dan, I don't know if you were going to ask about different materials, but love to hear what your thoughts are on that.
Yeah, I was gonna before I was gonna say a little bit that all the looks I get at Golden Corral now makes sense after hearing the analogy about the shrimp. But the
Golden
the
Corral.
what I wanted to ask was about whether maybe two things. One, the oligometastatic setting, for example, maybe single solitary spinal mets, and then how radiation plays a role into the decision for using a cage, because I think we're at MGH is, prime time radiation. Even if, you walk into MGH, you get radiated. So we're having a lot of discussions with our radiation oncologists about planning when to start radiation, and often what we're going to use, because they're going to, a big titanium cage is going to really make their job difficult.
Yeah, I think bringing up the oligometastatic lesions are pretty important. That's one of the reasons why I started a tumor board here at UCI, where right now every Fridays we talk about cases like that, because I think our radiation oncologists are moving more towards SBRT for those lesions. So you're absolutely right. If you're putting a titanium cage, makes that the dosing requirements more difficult. So we've been doing more and more carbon fiber in those settings. I think we have fewer of those kinds of patients, but they're very important to differentiate.
Yeah, I think that also brings up the idea of cost as well. And so, at the current, I think we have to be thoughtful. It would be so nice to just treat everybody the same, but I don't want to be treated the same as, a different family member. We're different, and I don't probably want to be treated the same as I am now in 20 years. My body will be different. So we do want to be somewhat patient specific. And so that's nice. But obviously then we have to control the cost containment. And I know that as we get not only oligometastatic, but some tumors are more likely to recur. Maybe the renal cell is one you really do want to, those when they recur are so painful when they start parasitizing vessels and such. So sometimes those oligometastatic renals versus say a multifocal lung cancer, to your point, maybe that changes our material too, for not only cost constraints, but because we're not necessarily treating every single level. So a case by case basis, a bespoke model. I'm different than you are, and I'm different than myself. We have to think about this. And sometimes people say, "What do you use?" And I often say, "Tell me the case, and I will tell you what I use." To your point, it depends, as you said earlier. That's always the right answer. It depends.
I wonder, Dan and others, your just your best guess of let's say of 100 patients you've operated on for spine metastases, what percentage do you think have gone on to a fusion? I mean, I know we don't know the answer to that. I'm just curious what your thoughts are, or do you even think, hey, I'm not worried about a fusion? This is not really the thing for them.
Yeah, I think for me, it's the answer is I don't know, but you're alluding to that it's low, and I think you're right for the obvious reasons. Sicker patients who don't have the ability to make bone, elderly patients don't make bone, previously radiated or chemotherapy, and then lack of time to make bone. I mean, basically every single factor that helps form a fusion, they are weak in. That being said, I have some patients with oligometastatic breast cancer who are solidly fused with a cage. Through and through. And I've seen patients who have loosened, and we got around that a little bit with cement. And then sometimes if the cement doesn't fail, then the rods break. So what we're seeing is if we get our wish, and our wish is to have the patient live as long as possible, I hope you spent more time trying to get a solid construct and fusion. Not that it necessarily happens, but those are the ones where we've kind of said, let's just do our best to get this patient out of their danger zone with spinal cord compression, and they surprise us. So I always leave the operating room trying to have the most solid construct, and I fuse, and maybe it's wishful thinking, but in those cases where they do really well, I guess we're prepared. I would say it's probably less than 10%, Joe.
Yeah, I mean, I agree, but I also agree with your sentiment, and that is we're all hoping these patients are going to live longer, right? And we all hope, and in some cases, as Dan and Hal pointed out, you have somebody that's expressing PD-L1 with lung cancer, they are living quite a bit longer, and so we're hoping in 5, 10 years these people are living, multiple years instead of now the median survival is half the people have not survived in 1 year. So I hope that the field changes. It is evolving. And it may be that the concept of really focusing on getting a fusion might become more important. I do attempt to get a fusion, but I don't expect that many of them do fuse.
Just wanted to take some questions from the audience if we have a second. Two questions here is, does the type of metastatic tumor play a factor when to use the cage or not? Which one's more favorable than others? We kind of touched upon that a little bit. And then does material matter in these cages when using a cage?
Yeah, I'll briefly answer. I think we touched on the second one. Maybe those oligometastatic where you're really doing high dose radiation, maybe that's carbon fiber. Also for the cost, it makes sense. You're really gonna, this patient might do really well because they have one lesion, so you're gonna have more durable follow-up. So maybe those are pushing more towards carbon. And then in terms of what was the first thing? Oh yeah, type of tumor is, I feel that when people do separation and they have a tumor, maybe like a breast or a prostate, where if you separate it and let the radiation take care of the rest of it, while renal cell, again, I often don't do separation for those. In other words, if I do separation, I separate the tumor from the patient completely. That's the separation, because you can't stop the tumor from bleeding, even if it's been embolized. So you end up these very punched out renal cells. We do more, and then guess what? Now you've done a corpectomy, and now you've got a big hole. So maybe more of a cage there, while maybe the prostate and the breast less. So I'd love to hear what other people think.
Yeah, I was gonna say, I was looking at the survival rates recently. There's a paper out of Korea where they looked at survival rates for all their different kinds of cancer, and they compared it by decade. And it was breast, lung, and kidney cancer where the patients were surviving longer than a year, whereas cancers like liver, like colorectal, still weren't seeing as much of a mortality benefit. So I thought that paper was interesting. So the patients who I expect to live longer would be the ones I'd more likely use cage on.
And even within that, right, there's the subgroups, as we mentioned, different histologic subtypes, and that really. So it's not just histology. I think your point's well taken, but certainly we have to individualize it.
Yeah, I think it depends is the perfect answer for for metastatic spine unit. There's so many variables that go into this that you just beyond histology and how big the lesion is, location, all really plays into it.
So in the last minute, Dan, maybe as the moderator, the chair's prerogative, any summary points that you'd like to bring up? I know Rory Goodwin just joined us, who actually wrote a paper on how colon cancer of the spine has a poor prognostic. What did Dr. Goodwin write? At what time point? Can you read that one, Mo?
Sure.
Oh, here we go.
So
At what time point do you think there will be break-even point for placing a cage and going for fusion, especially as target therapies become better and better? 2-year survival, 1-year survival. Obviously, you heard one comment. 1-year survival was a bit of a tipping point. Any other thoughts?
I mean,
I
I
think
think
it obviously depends, right, Dan? Go for it.
yeah, no, I was going to start by saying it depends, but I think perhaps the survival is not the overwhelming endpoint for it. But I appreciate Roy's question. I think it's more, does this person need biomechanical support? For example, if you take half of a thoracic vertebrae, but you have augmented screws above and below that, you have the ribs still attached, that patient may survive 6 months or they may survive 6 years, and they're going to do just fine because that's not going anywhere. So I think, the void that's created, the rib resection that's created, the location, those are all, to me, variables that are used perhaps more so.
Well said. And that kind of brings us full circle on this edition. It depends, and these are some of the factors, as Dr. Tobert said. Well, the time is up, and we want to thank all of our speakers. We want to thank all of our attendees too. Again, NAS Oncology and Icotech, and definitely the Seattle Science Foundation. This episode and this platform occurs every month, so we're looking forward to a number of group speakers from the NAS Oncology group to present next month, and we look forward to having you all here. And thanks to everyone who was here.